So hello, everyone. Oh, thank you, Joy. Hello, everyone. Welcome to September's Advocacy in Action webinar. My name is Sam Miller. I'm AOPA's State and Federal Advocacy Manager, and I am joined with some special guests today. Terry Kuffel of Arise, and AOPA's President-elect is with us with her Minnesota crew to talk about a recent advocacy win in the state. I can kind of go over a quick rundown of what this win is. Essentially, this is a change to Medicaid's lower limb policy in the state. K levels are now aligned with Medicare. There are a few microprocessor devices that are now covered for K3 and above. That's ankles and knees. And then there are a few previously unlisted codes that are now added to the fee schedule. That's multi-axial ankles with swing phase active dorsiflexion features and vacuum suspension systems. So we're kind of here to ask Terry how she did it, ask the crew how they went about this, and see if hopefully everyone listening can learn a thing or two to help with their own advocacy efforts in their states. So Terry, crew, everyone, how did you find out about this issue with Medicaid, and when did you decide that you needed to do something about it?
Okay, thanks, Sam. Thanks for giving us the quick lowdown on what we're talking about. Appreciate it. I've got our fantastic crew here from Minnesota. So I'm going to ask each one of them to introduce themselves, and then we'll get into basically how it started and what we did about it, and quite honestly, how fast we got things done, which is not the norm, but we will share those details. So I'm Terry Kuffel of Arise Orthotics and Prosthetics, Minnesota. I am AOPA's president-elect, and I am also part of MSOP, Minnesota Society of Orthotists, Prosthetists, and Pedorthists, and Wiggle Your Toes nonprofit. So in that note, I'll hand it over to Charlie. Are you on, Charlie? There we go.
I am. So Charles Kuffel, and with the Rise Orthotics and Prosthetics, Terry's my better half. So we kind of manage these processes together as a small company in Minnesota. I'm involved in NCOBE for a lot of years. Education I find paramount in really getting changes made within our industry. And I'm just happy to be part of this call. Appreciate it.
Okay, Kimberly, are you with us? Thank you.
Yes, hi, I'm Kimberly Hansen. I'm the Director of Reimbursement for Otterbox, North America. And I am also a board member of AOPA, but a resident in the state of Minnesota, and happy to be a part of it. Thanks for inviting me.
Great. Aaron?
Kimberly, are you officing out of the garage? You kind of look like you're, yeah, my name is Aaron Holm. I am a manager of consumer engagement for Otterbox North America. I'm also founder and executive director of Wiggle Your Toes, a nonprofit based out of Minnesota that supports the limb loss, limb difference community.
Okay, and Elisa.
Hi, I'm Elisa Kovala, and I'm the administrator here at Tilges Orthotic and Prosthetics for the accounts and services. I've been involved I've been here for 14 years and just have done prosthetic advocacy for a lot. I was thrilled to be able to jump in and help with this. And I had noticed the policy a while ago was very much not in line. And we had several patients that needed these. And so it was exciting to be part of the process.
Thank you, Elisa, for teeing that off as to how this came about. So actually, I got a call from Aaron saying that we had some consumers in Minnesota that were concerned because they received denials through one of our providers. And actually, we had heard that there were a few this year. And so we realized this is actually how we have been involved and stayed involved with Minnesota Medicaid for the last 17 years since Charlie and I came to Minnesota and started to get involved. It's usually something doesn't quite sound right or smell right. And that's with regard to, the times are, the devices, the care and the times are continuously changing. So the policies have to do so as well. So we were alerted to the issue with MPK a denial for a K3 that was definitely justifiable, and we all felt so. So Aaron called me. I communicated directly with my most recent contact at Minnesota Medicaid, and I will tell you, this person, the person in charge of us, they're usually policy managers, and I think Becca is now our 5th representative in the last 17 years. So every few years it changes. So I had connected with the prior contact that we dealt with last year, and certainly, sure enough, she transferred me over to Becca. So Becca was the person that we connected with, and we said, this policy. Oh, does someone? Can everyone go mute? We're getting some feedback. Thank you. Thank you for joining us.
19405-1383.
I think that's, I think we're good.
That's Lauren
Okay,
Rainey. Lauren, yeah, thanks, Lauren.
Okay, super. So Becca, it didn't take very long. It took a day or two to get connected with Becca, who was the new point person. And she happens to be a physical therapist who had just started in this capacity a few months ago and recognized right away that the policy was outdated. It hadn't been reviewed since, I believe, 2014. So basically, in a nutshell, it said that MPKs required a K level of K4. And so she agreed with us instantly that it should be K3. So from the moment we started the conversation, it was pretty much downhill from there. It was a yes, we're gonna look at this. Yes, we need to change this. And what else do you need? Could you all scrub this policy for me and tell me what other changes need to be? So I don't think a call like that comes very often in our industry in Minnesota or nationally. And so we said, we would love to do that. So we took our time and we all scrubbed the policy. We had a meeting on the side, a couple of meetings on the side, gathered our information. Kimberly is a wealth of the case studies and the research that we can provide and attach quickly instead of trying to find them ourselves through Otterbox. She has access to all that information and quick links, and it's such a tremendous help. Really just speeds up the process. So that's pretty much how it happened. And these are our main players. And I guess you've got a list of questions for us. So I'll stop there and see, Sam, what's next. And I would encourage all of the Minnesota team to pipe up and in when appropriate.
Yeah, absolutely. I think this that last part of your story kind of dovetails with the question I was going to ask. Is you've assembled quite a team who kind of each bring their own specialties and strengths to the table with getting this done. And how did you kind of go about assembling this group to address this issue?
Okay, so we've got Elisa, a very strong reimbursement specialist manager for one of our providers here in Minnesota. Kimberly from Otterbox, and Aaron from Wiggle Your Toes on the consumer perspective. And then we had Charlie there to help support from the practitioner view. So let's see, Elisa, did you want to share a little bit more about your connection to this?
Sure. We were one of the organizations, one of the companies that had some patients that were getting these very unusual denials. And Minnesota Medicaid, we knew the policy was K4, and it was even what I would consider it was K4 plus. They had to have the need to use a variable cadence over 400 yards on a daily basis and or on uneven terrain on a daily basis. So it was this extra piece of it. So for just straight medical assistance, we just never even went there. We never even asked. But there were a couple of the takeover plans like the health partners or the Medica plans in the state. And we knew that if we would try to authorize with them, it was almost always a go-to for just K3, no problem. And then we got these denials. And then Aaron called me and he said, "Hey, Elisa, are you getting any denials?" And I said, "Oh, by the way, we are." And we're just, why? All of a sudden, I assumed that there was some new person that had kind of said, hey, you need to start following the K4 rules because that's what the MA policy says. And I had told our practitioners for years, here's what it is, it's spelled out, this is what they're saying. So we were able to turn a couple of those authorizations around for these patients now. Becca was a dream to work with. Weirdly, both Erin and I were connected to her in ways outside of the medical arena. I had a daughter that went to school with her, and it was very interesting just in that aspect. And so then we all took a look at the policy, and I kind of put in my input on what I had been talking about for years, and then some of our patients now I'll have their microprocessors because of this. So it's very exciting.
And I had originally heard about it from Paul Lycum. I think we were having lunch or a beer or something, and he just brought it up like, this is happening. And with my consumer hat on, I kind of called BS on that, and very, very concerned about the future of the consumers in Minnesota, not Otterbox behalf or wiggle your toes, but the people like myself who depend on these products are basically going to have struggles getting the products, and they're going to need them more and more as they age. So that's what sparked me to make some phone calls, Elisa and Kimberly and Terry and these guys. I mean, this group just they continued to reach out and to network. We brought in Winkley, they brought in Advanced Arm, and these specialists, that are typically siloed. They broke down those silos and communicated with each other, and it's moving along incredibly well. So it's kudos to that team that was built up by this group and the connections that are made and will remain. So cool.
And I would add on to that, if you can hear me. I looked back at the history of us trying to use clinical evidence alone to change medical policy. And we had submitted 11 times to the leadership at medical policy group at Medicaid Minnesota, and 11 times we received no responses. So this really shows the power of coordinating a denial with a patient, with a couple different affiliations, a couple different O&P shops, to come together to really show the power of unity in your community. Because I alone, with clinical evidence and asking for K2 and above for MPKs and vacuum and hydraulic ankles, was not enough, because nobody in their eyes was impacted. It looked very self-serving from the manufacturer side with these products, even though the policy adds on more than just what Otterbox offers. And so that really is the power of the unity of the community of coming together with the patients, with the denials. Or if you have a really strong patient and you don't want to go at risk yet on your denial, that's a great case presentation for the medical policy group to review. And I think one of the other things is immediately we've invited her to local shops to see a fitting, to see the evaluation, how they select the most appropriate product, and really going down that path. That was an invite that was always open and still continues to be open for that group.
Great, thank you all. Charlie, did you have anything to add?
Yeah, if you can hear me. It's, and again, I kind of go back to it's about education. And we had a follow-up call with a group out of, I believe New York, and they were looking at things like, we're hiring a lobbying group to write white papers and all these type of things. And how did you guys do this? And was it within within a payment cycle? And what we found with the group that we put together, and this is not a one-time off, we've done this throughout the years over the last 17 or 18 years, is we have a good group of people who have the patient as well as the insurance company's best interest at stake, and through simple education at what we do and the benefits we bring to their beneficiaries who need, who are limb loss or who have orthopedic concerns requiring orthotic intervention. So, it was a great group to work with, and we have made some great strides, and it really came down to education. One part of this won't change the trajectory, but you get a good group of people together, and we are blessed with good providers in the state of Minnesota. We have good players in the sandbox, and insurance companies recognize that. So I think that was a big a part of our successes, the successes we've had in the state of Minnesota.
Thank you. There's two things I want to add to what the group just said. First of all, Elisa talked about we seldom went to Minnesota Medicaid for these types of issues. We know that Minnesota Medicaid, well, in the past, at least in the past, I would say, 10 years or so, we would seldom go to them because the response was always, you have to work with least costly alternatives, period. And so we really felt like the time had come where there has been so many advantages to the MPK at the K3 level that it was really time to let them know that this is always an option for them to say no or review the prior auth and say no. But there were definitely some people we felt like this could serve well to the population for all the safety measures that it provides. So that was number one. And number two, Kimberly had made mention of, from Otterbox, she had communicated with Minnesota Medicaid 11 times. What it really took was this group of people together, but also a few examples of what I call standing. It's a legal term where you've actually got a claim and a person who's actually affected. And that is what starts the process, where you've got an example and several examples of something that isn't quite right, or something that, or if there's any harm. And in this case, it was obvious that to us, the group of us, that there was a select few patients who were starting to receive denials on care and devices that we truly felt were justified. So, and I think that is what triggered. It also triggered, I think one of your next question is, how did we establish this relationship with Minnesota Medicaid? So I'll just roll right in if that's okay, Sam. So it's been, 17, 18 years that we have been working with them. And that literally started when we came to Minnesota. Charlie and I opened up shop, and there was a prior authorization that was denied. So he picked up the phone. I picked up the phone on the front lines, and then I got to a certain point, and then Charlie picked up the phone, and we went all the way to work with Camille, who was actually in the position that we're talking to now. So we went through the front lines for your benefits and eligibility and your provider relations, and then we got to her, and she said, oh my gosh, I don't understand why. Of course, we need to change this policy. It was the same type of trigger reaction that Becca had. Yes, we need to do this. And can we get together? And so it really took, that's what started it so many years ago. And then Charlie and I and other representatives in Minnesota, through the Minnesota Society of Orthotists, Prosthetists, and Podorthists, and Wiggle Your Toes, and with the help of Otterbox, we kept the relationship going. So every couple of years, if I heard of a reason to connect with them, I did. And so this is the fourth time we have worked with them one-on-one. We worked with them on a policy review twice before this. This is the third time. And we also worked with them on the cranial remolding orthoses to increase our reimbursement. And that was about 7 or 8 years ago, which was, again, incredibly successful, the success we had there. So it's establishing the relationship based on good cause, and maintaining that really at any point along the way that we felt was needed, not unnecessary, but needed. And then, as Kimberly mentioned, we invite them to our facilities. I mentioned Becca is our 5th manager. The prior 4 managers all have attended our annual meeting, the Northern Plains chapter, the Academy meeting that we have here in Minnesota. So we have put an invite out to Becca and any of her staff to come join us in October for the meeting this year. They don't always come, but they have all come over the past 15 years or so. So that is how we established and continue to maintain the relationship with the representatives at Medicaid who govern O&P.
Absolutely.
Terry, it's Joe McTurnan with AOPA. Sorry. Hello, everyone. If I could just add to that, I mean, the relationship angle is so important to anything you do from an advocacy standpoint. And it's always best to proactively build those relationships. So if you're working in those relationships before you need something or before you have an issue, that establishes you as a trusted partner and a trusted ally per se. So that when there is an issue, now you have somebody that you have an existing relationship that you can go to. So then you're just not reaching out and saying, I need this, I need this, I need this. So, inviting those folks to come into your facility, inviting them to your meeting, saying, hey, this is what we're all about. We want to build a strong working relationship with you and your organization. It's so valuable, and it pays tremendous dividends when there is something that comes up like this issue, where you now have a contact, you now have somebody that is not automatically defensive and saying, okay, these people just want something from me. You have folks that trust you and understand, you know, that your motives are good and intent. So just wanted to add that. You said it very well, but it's so important.
Sure. And I will just mention that again, the person who sits in this seat and has these responsibilities keeps changing. So it hasn't been easy to find who the next person is. But we have, you know, persistence will get you everywhere, right? You practice your patience and your perseverance and your persistence. And that's what we've done. You know, the torch would be extended to the next person, and we would find out who that is. And again, we don't communicate with them unnecessarily. And so I think that's key as well. Sam, I was just looking at your questions and we've gone through a lot of them. So you let me know what's next.
Yeah, sure. I think that it sounds like I was going to ask if there was kind of a negotiation process, but it really sounds like you and Minnesota Medicaid were on the same page and working together. But if there were ever situations where you kind of had to have an ask and kind of meet in the middle with a regulator, do you have any kind of advice or tips for doing that?
Sure. Actually, in this particular situation, you know, we thought, okay, we want to move from K4 to K3, but let's ask her for K2. And so that was challenging for our group. And, you know, I will ask Elisa and Kimberly to talk a little bit about that, if they could share.
Yes, we all know that the microprocessor is so good for K2 patients and helps them move along and get to that K3 level, and sometimes and for safety. And so it was a little bit of like, are we asking for too much? And Kim's the pump code and just getting all that in there. And I think after we all talked and sort of revised and made that policy the best that we could, it was great to see what they were willing to listen for. So I think always go for the most that you can when you're in that situation, and see if you have to negotiate. We've done this with other companies. We had another insurance company in town that we were not being able to get any K3 feet at all, period. And so we met with their medical director and their whole entire review team and had the complete explanations of everything from what the suction socket was, what this other type of socket was, and so that they understood the codes that they were looking at. So again, get them in the door, get them in a Zoom meeting, have them get the education. So important. And go for everything that you can possibly go for when you have that meeting.
You know, I'll just add on to that, Elisa, that and group, we supported our request with the clinical evidence that we had on file. And it's much easier to do on a lower limb policy than it will be for an upper limb policy. But we really relied on the evidence and cited the evidence in order to show how the patient can function better or have a better outcome because of the most appropriate device. So it was really something that we referred to the science instead of our opinion on.
Thank you, Elisa and Kimberly, for adding that. Sam, I'm going to preempt your next question about how long did this take? It was quick. And I will tell you that was not common. But I think she was on board from the minute we started. And we had 6 specific asks, and she granted all 6 asks. So again, not the norm, but very excited that we were able to present, gather a group of respective people who could share each part of this, from the consumer perspective to the backup and the research for the day-to-day. And we had a practitioner on to answer any questions. So that was really key to being able to get this over the finish line. And I think from start to finish, it was maybe 2 months. So, and again, not common. Sam, if I may, because of time, I'll just go to the next one, which is what's next?
Yeah.
What's next on the radar? And Aaron let the cat out of the bag a little bit on this one. So through this, Becca asked us if we would help her create an upper limb Minnesota Medicaid prior authorization policy. Minnesota does not have one, and most states do not have an upper limb policy. So we continued with this small group, and we've added a few other O&P providers, local providers who we know specialize in upper limb. And so Kimberly alluded to that as well. It's going to be a little bit more challenging. There isn't a current policy in place for us to work with. She is starting from scratch. So she gave us a bare bones outline, and then we spent a few weeks, and our group has expanded from the 5 of us to include 3 more facilities and representatives from there on upper limb. And so we worked, it's hard to get everyone together at the same time, the same place, but it's easy to pass around the draft and have someone take the time, and everybody is vested in taking the time and interested in sharing their input and their knowledge, all for the better of our patients and the individuals here in Minnesota. So it was Kimberly took the lead on the upper limb. And before I go any further, I'm going to ask her if she'd like to share anything about what we're doing next.
Yeah, if you can hear me. It was exciting because there's very few upper limb policies that are super favorable to a lot of fantastic products that have been out for a while. So we did take liberties on myoelectrics, articulating digits, 7499 codes to be added to the policy. I mean, this is one that negotiation, to your point, Sam, may take place because there's not a lot of science to support it, but there's a lot of patient particulars in work and life and ADLs that would require some of these products. So we really sold it on that. And we even added in a portion of the main law about recreational and sporting activities, and we coined it differently, but really for the patient to actually build stability, mobility in order to achieve greater ambulation on the upper limb. So I'm excited about it. I can't wait to see what comes back on this one because we did not have as much supporting evidence, but we did push the envelope on our request again. So we'll have to keep you in the loop on how this one goes.
Yeah, great. Elisa, did you have anything to add on that point?
No, I think the next thing is after this one, United Healthcare. So, there's a lot of places to go. So just excited to move forward at that. But yes, the upper limb, we have a lot of patients with the articulating digits and then even the mechanical digits and adding in that 7499 and kind of rephrasing recreational to health and well-being activities so that it kind of takes that, it's not just something fun, but just a little bit more, it's needed. That kind of helps. We've used that phrase for quite a while because, when they started putting that recreational in the policies, we had to figure out a way to get around that. So.
Most definitely. I think in the interest of time, I'm going to ask that we take a second to honor the Advocate of the Month, if that's all right with everybody. So this month, we are going to be awarding the Advocate of the Month to Jim Kaiser for his help with Illinois' Medicaid fee schedule updates and also for his participation in the Wounded Warrior letter writing campaign, which I will plug as being found on the AOPA Facebook page. So if you'd like, and you haven't done so already, check that out and write a letter to your congressman to support the Wounded Warrior bills that are going to help education and research in O&P.
And Jim, keep an eye out in your email inbox for your glorious prize, which will be a $15 Starbucks gift card.
I almost forgot.
From me. So
Wow.
enjoy 1.5 cups of latte or espresso on AOPA.
Well, thank you all very much. That was totally unexpected. We're kind of like Terry. We're still plugging through Medicaid, several layers, but you know, it's working right now. We're going to add 58 codes, Medicare custom codes, to the schedule as of January 1st. It does include the microprocessor stuff and minimal upper extremity myoelectric, a BE. Just to give you a quick note on it, we started this thing by taking the current Medicaid codes and actually getting a rate increase back in 2019. And that left about 126 L codes that were on the Medicare schedule that were not on Medicaid. So the stage 2 of this was to add some of those Medicare custom codes to the Medicaid schedule. So out of the 126, we're ending up with 58, mainly because the very high-end upper extremity stuff, you know, the scapulothoracic, the state just couldn't quite deal with those kind of published reimbursement rates. So, you know, you compromise. So we took a BE and we took some lower extremity stuff, and we're going to get those in, and then we'll go to work on some other stuff next year. So, but anyway, thank you for, I did not expect this, this bit of recognition. My good colleague, Lori Johnson, I saw got it last month, so she's a good friend. So thank you very much.
Hey, Jim,
Absolutely.
what state are you in?
I'm in Illinois.
Okay. Terry, didn't Becca state at the last meeting that she was in contact with the team from Michigan?
Michigan, yep.
And that she was going to share the policy once the policy is rewritten. And I think that's another huge thing to consider here is these guys, these groups talk to each other and they attend conferences just like we do. And you get a good policy written and encourage them to share it with others, might go a long way. Save us some work.
That's a great point to add, Erin. And she's excited about the idea of creating a policy that other states can follow. So this, honestly, I don't know how we struck it. So great to connect with her, but we're going to roll with it and work with her with whatever she asks of us. And yeah, we'll see. We'll hopefully see fruits of the labor.
She's from White Bear, Terry, so it's easy stuff. Go Bears.
Well,
Right.
Good Fargo reference.
We'll take that any day.
it looks like, Stas, you asked a question about where to find Medicaid policies. I think, would you know a good answer for that, Joe, like specific resources that she could use?
So, I mean, if you're going to go searching on Google, they're not always easy to find. But if you look if you Google like your insert state name here, Medicaid medical policies, that will usually get you there. Usually after clicking on about 7 links that don't get you there. But we do have a service called Policy Reporter, and if you are a member of our co-op, we do regularly post policies, Medicaid and Medicare policies on our co-op and state-based policies on our co-op. So that's always a good resource as well. We try to keep that as up to date as possible.
Yeah, I called
Sorry,
two
did you have
people.
something?
Well, I called 2 people. I called Kimberly because I knew she has an arsenal of information at Otterbox, which I believe OSER does as well. And then I called Joe McTurnan and I said, okay, this is what I need. You know, are you willing? Do you have a bank somewhere where you can send? And so it was great to work with both parties.
Yeah, and if you have any questions, like please contact us. We can help steer you in the right direction for sure. Well, I appreciate everybody coming today. This has been really helpful, Terry and team. This has been really informative, and I hope that people can take some good advice on how to advocate in their own states for changes to policy. And I really hope to see you at the next Advocacy in Action. Hope everyone has a great day.
Sam?
Yep.
It's John Schrader. I have a quick question. I put it on the chat, but I don't know if anyone saw it. In the discussions with the policy managers and the medical directors and the review team, was there any pushback regarding the cost to the program of approving all these new services?
Nope. Nope. Cost was not mentioned at all. I know that's rare. I absolutely know that's rare. But again, this wasn't, well, it wasn't a legislative move. This was a, internal policy move. So there was no CBO scoring or what have you. And again, this is the fourth time we've worked with them, and there's never been a conversation about cost.
So apparently there is money in the budget somewhere that they can draw upon.
Minnesota is in a surplus, but yeah, and that is not common either. But I do honestly believe that we are not abusive to the policy, and we are very careful about if we recognize, and we even wait. I mean, our communication with them was delayed. I would probably say a few years. Wouldn't you say, Elisa? Because we had, but we were careful as a community to work with devices that we thought were the, least costly alternatives, which is what we knew they would come back with when we started the process. So it just, got to a point where, over time and the amount of patients that it was necessary. So, but back to your original question, we did not have conversations about cost.
And this is Charlie. And I think we also had an open ear on their end. So although the least costly alternative in most cases isn't a microprocessor knee, when you look at longitudinal data, which Kimberly pointed out, it is the least costly alternative because of the reduction of comorbidities. So we had an open ear. And they recognize that. And as soon as we educated them, not only from the clinical and administrative and research standpoint, they immediately recognized the error of their ways. And that's why policy changed so rapidly. The same thing happened when we did the cranial remolding years ago. As soon as we pointed out the error of their ways, educated them on the processes, they immediately changed policy. So it's been very refreshing to work with in the state of Minnesota.
So Charles, which longitudinal data would be a good reference?
And I would defer that to Kimberly about, we look at Dobson, DeBonzo, and some of the historical data that's come out, the RAND study that shows just the reduction in falls reduces the overall cost to the healthcare system, not immediately, but certainly in long term. If you have a listening ear, that is unbelievably impactful. Because everybody looks at the initial cost of something. Well, that MPK certainly is more expensive, but when you go 2, 3, 4, 5, 7 years out, we're saving these insurance companies money.
And where can I buy these listening ears? Are they sold on Amazon?
John, well, I would be happy to help you. This is Kimberly. I would be happy to help you with your pursuit of trying to help change policy there as well. So, the science is available, and we have all the studies, and we have access to be able to distribute them at no additional charge. So I'm happy to help you look at your policy. And we were fortunate. We looked at their draft policy, and we picked it apart, and we put everything in we wanted. And that could be something that we do if you can work on the engagement with a patient and a claim and a denial, and some, a patient that's really willing to pursue that. It will eventually result in a conversation. May take some time, but we could definitely have the back end of it ready on what our ask is. And I would be happy to help them work with you on that.
Very good. Thank you.
Just a comment from Illinois on that. Terry's a better convincer, I think, than I am with the HFS and the folks you deal with in Minnesota, because we literally have to go through the General Assembly in Illinois. And that was required because we got the rate increase, in 2019, which is set at the prevailing Medicare minus 6%. And so even these new codes that were getting put in as of January 1st, we had to go back through the General Assembly and get basically a projected cost, which was kind of tricky to do. It was very tricky to do. Because again, those rates will go in for Medicaid and the managed care MCOs at Medicare minus 6%. So we needed some money to be able to basically, play with, in the sense to get those codes approved. Once we got it approved through the General Assembly, then our Medicaid and our HFS were great people to work with, because we've had good contact with them for literally 20 years also or more. So, it just kind of depends on the avenue you can take and who you can convince, the quickest and the easiest. I think Terry did a great
Sure.
job, much
Sure.
faster than us.
Well, and Jim, to that, I will note for those interested, and if you want to stay another minute, in January of 2020, a Medicaid representative reached out to me higher up than Rebecca in policy and said, we have an issue that's going to require a change in the law in Minnesota. And the issue is the prescribers. And unfortunately, we can't fix this in Medicaid policy, DHS policy. We have to change the law. And we know MSOP exists. We know that you're part of it. Can you help us? And I said, well, sure, of course we'll help you. What would you like us to do? And he says to us, you need to change the law to expand the scope of prescribers in the state of Minnesota. And it has to be done legislatively. And so to your point about cost, and at this point, or when we did that, I communicated with our O&P providers across the state of Minnesota. And I basically said to each, I need $1,000. We got to collect about 25 grand to engage the lobbyists because we have to make this legislative move. Not when we have to, because they're asking us. They're reaching out and asking us. They say they know the law needs to be changed. And it was basic. It was so basic. It was just to expand the scope of prescribers for O&P in Minnesota Medicaid to match that of Medicare. And that couldn't be done any simple way but for to change the policy. So in that effort, we very quickly rallied the troops. We had probably about 95% buy-in from our extended community. We engaged the lobbyist. We got the draft written. And in March 2020, about a week before the pandemic hit, it was signed by the governor. So it actually attached to another bill. I don't quite know how that happened as quickly as it did, but the point there was they came to us, they asked us, we did need to provide some funds to get that across the finish line. We did what they asked, and I think that helps that to us have established the relationship that we have in Minnesota. They know who we are. They know they can call upon us, and we don't hesitate to call upon them when the need is present.
Yeah, that's important. They got to, we're still on monthly conference calls with HFS and the managed care executives, just regarding operational issues that need to get fixed, that are just crazy, like bilateral AFOs for CP kids, and they approve 2 and they pay for 1. And then you got to go back and argue about the second one. I mean, we had that fixed a year and a half ago, and then it just reverted back to the same problem with the MCOs as they change basically, people that make those decisions or their system.
Mm-hmm.
So it's constant that you have to maintain with those folks.
Yep, agreed. Well, we'll take the wins when we can get them, and we will scream loudly. We will blow the horn at the top of the mountain. And we can share the news that, we've had some successes, and AOPA has had many successes this past year with regard to their communication and their efforts at the state level across the US. If any of you have seen Sam's weathercast, his forecast, several of them now, if you haven't, I implore you to go back through and look at them. So Sam, here, I'll throw it back to you.
Oh, thank you. Yes, please check out the weather reports. They're really fun to make. But this has been super informative, and I think that everyone can kind of take something away that they can use in their own practice of advocacy, in whether it's at the the regulation level or it's kind of within their own practices. And I think that this is something that we need to continue to work on. And as Terry said, celebrating those wins, making sure that people know about them is very important, so that somebody else can come to you and say, how did you do that? Like we're doing here. So I appreciate everybody coming on. Jim, congratulations again. We will be sending you that email, and I hope everyone has a great day.
Thank you, Sam.
Take care, y'all.